ما شاء الله العدد 230 إلى الآن.
We have
أعتقد على اليوتيوب أكثر يا.
ما شاء الله العدد 230 إلى الآن.
we have
طيب، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. كل عام وأنتم بخير. أتمنى لكم إن شاء الله صياما مقبولا وإفطارا هنيئا. تقبل الله طاعاتكم، وحياكم الله جميعا في هذه الندوة اللي نشارككم فيها ونتكلم عن الكوفيد 19 and its effect on otolaryngology specialty. Let me share you my presentation and then we will go through it. I hope it's already there. You can see it now. Confirm it. طيب. أخوكم مساعد الزهراني من المنطقة الشرقية الدمام، مستشفى الملك فهد التخصصي، الأمين العام للجمعية السعودية للأنف والأذن والحنجرة. I will be moderating this session مع الإخوان الزملاء من الرياض ومن جدة. نرحب أولاً بروفيسور at King Saud University, Director of King Abdullah Institute for Ear, Director of King Abdullah Ear Specialist Center. He is also the President of the Saudi Society of ENT and also the President of the Arab Academy of Otology and Cochlear Implants. أهلا وسهلا بروف حجر.
السلام ورحمة الله وبركاته. وعليكم السلام، يعطيكم ألف عافية. Thanks a lot for inviting me.
شكرا جزيلا لكم. نرحب أيضا بالدكتور محمد القرني، Consultant ENT, Head of the ENT Department, National Guard Hospital in Jeddah, and previously the Vice President of the Saudi Society of ENT. دكتور محمد حياك الله. بيكون معنا إن شاء الله قريبا، أتوقع أنه فصل معه. والدكتور طلال الخطيب، Associate Professor, King Abdulaziz University, Jeddah. He is also the President of the Saudi Council of Otolaryngology. رحب فيك دكتور طلال وشكرا جزيلا على انضمام اليوم.
الله يحييك وشكرا لكم والجمعية السعودية على الاستضافة الجميلة هذه.
شكرا دكتور مساعد. Thank you very much.
حياكم الله.
Thanks for the invitation.
حياكم الله.
الله يبارك فيك.
So I will start this lecture by an introduction about the COVID. I'm not sure that I will be adding anything. I'm sure this يعني pandemic has been يعني all over the places, and most of you participants know probably better even than me. But let's have a recap of what happened since the beginning. In November, end of November 2019, there was a pneumonia-like disease of a cause detected in Wuhan, in China. And then officially reported case on the end of December 2019, reported a case of the first virus infection, confirmed infection. It was 1 month later when the outbreak was declared as a public health by the WHO, or the World Health Organization. Later on, it was given an official name by the 11th of February as a COVID-19. This is where we are yesterday, in fact. This is the statistics of yesterday. Worldwide, there is about 3,991,000. I believe today exceeded already 4 million. There is about 280,000 deaths worldwide. The statistics can be followed up daily by the Johns Hopkins. There are a lot, even in the WHO, they give also their daily statistics about it. Now in Saudi Arabia, and this is also a date of yesterday, 37,000 cases confirmed and 200 plus cases of deaths. I have to move my, so I can see, yeah. There are 10,000 cases recovered. And the daily deaths, I'm not sure if it appears here, but it's about 200 something of deaths. So why we wanted to call everybody to this lecture and to emphasize on the risks that we have as ENT. One is we know from previous infections, previous coronaviruses like the SARS and the MERS, we know that the viral load in the nose and the nasopharynx, which is our area of expertise, the load is very high. In this pandemic, in the beginning of this pandemic in China, a single endoscopic skull-based surgery in China resulted in 14 operating room healthcare workers becoming infected because of this high viral load. Also, there are findings supported elsewhere in Italy, Greece, and Iran also, that there are about 40 ENTs who are suspected to have infected of coronavirus, and 20 of them are hospitalized. We also remember those of our colleagues in UK of Egyptian and Sudanese origin, الله يرحمهم ويتقبلهم إن شاء الله من الشهداء. They were ENTs, I believe the first one and the second probably. But it is very serious issue on our specialty, very serious issue on our personnel that we have to address it and educate about it and about its importance. How did it affect our practice? We don't have yet official data from Saudi Arabia. We have our personal communication. We know that most of the governmental hospital, I would say all of the governmental hospital probably, has suspended the elective cases in outpatients, as well as in operating theaters. But this data is published as of this month in the Otolaryngology head and neck surgery coming from Italy, where they compared their statistics of 2019, same period from the from March, 18th of March to 12th of April of both years, 2019 and 2020. The cases that attended the outpatients in 2020 was 12.9%. This is the diagram, you see it on the left side. Compared to 62% in 2019. So there is a tremendous drop in the outpatient visits. Most of the cases that attended lectures, that attended the OPDs were the oncology cases and the emergency airways. On the right side, we can see that there is, this study coming from the US. On the left side, we see this diagram where they compared the mode of visits, that is either in-person visits or by telecommunication visits, such as what we are doing now, or by telephone, or by video communications. So you can tell this is the weeks of March, 1st of March until the end, until the 10th of April. We can see by the weeks going on that the visits of the telecommunication has increased, especially in the third and fourth week, while the in-person visits have decreased tremendously from the first to the fourth week. So yes, there is an effect on the outpatient visits in ENT. The second thing this study coming from Italy, comparing the 2019-2020 of the same period, the month of March, the elective cases in the operating theaters. What we can tell, 2019 now is in the red color, 2020 in the blue color. You can tell by looking at the first column, head and neck cancer has not dropped So yes, there is a drop in elective cases, but we cannot compromise the patient care. Cancer patients, they cannot wait. Probably we will see this throughout, inshallah, the lecture مع الدكتور محمد القرني, who will speak to us about the oncology cases in ENT in Saudi Arabia. Other cases has dropped a little bit, but still there is the upper airway management, some of the abscesses, nasal bone fractures, but all of the other elective surgeries were nil, were zero. You can see on the other, on the right side, the cases are almost all head and neck cancer. Some of them are airway managements, little of abscesses, and about 2 cases nasal bone fracture. Now, what are we doing to defeat this pandemic? If you go to the clinicaltrials.government, this is the NIH website, you will see that there are a lot of studies now undergoing. Most of them are divided in 2 big categories, either antivirals, chloroquine, hydrochloroquine, and we have heard a lot of it in association with azithro or without. Now, we heard recently that the remdesivir has been approved to be distributed and to be officially marketed. Also, there are some medication that have been used for HIV treatments are still under investigation. The other category is the immune-based therapy, and the most common is the convalescent plasma from those who are infected with the coronavirus. Some are also testing the interleukin 6 and interleukin 1 inhibitors. We still have no clear vision about it, about its efficacy, but at least the remdesivir is approved already in the States. Now in Saudi Arabia, the King Abdulaziz city has initiated a fast-track funding program for the COVID-19. A couple of, probably a month now, a couple of weeks, the results were out, and they sponsored 42 research proposals on the COVID-19s. We can see some of them are talking about the plasma in treating the COVID-19. Also, some are studying the genetic factors behind the variation of the symptoms. Yeah, the studies has a lot of variation, and some of them are addressing the treatment, some of them are addressing the detection and otherwise. So that has been said, we will, inshallah, go through this lecture with our speakers. We will keep the questions to the end, inshallah. We'll have 15 to 20 minutes of questions. So if you have a question, please write it down and keep it to the end of this lecture. We will now give the mic to Professor Hajar, who will share with us his lecture and his vision about this COVID-19 and its effects on the otolaryngology specialty. Prof, the mic is yours.
Thanks a lot, Dr. Musa'ad al-Zahrani. I'm really honored and delighted to be among those scholars in the field of ENT, whom I'm sure I'm going to learn from them and from their experience. As you have said, my specialty more of an otology, and we are not in the tract of emergency. So most of the cases goes to the head and neck guys, as well as the head and neck guys, as well as the airway. So I'm having more time as a university doctors to spend in research as well as in education. If you look to the society in Saudi Arabia, it's one of well-established society which been in the medical field for the last 26 years. And we are trying to gather all the ENT specialists under one umbrella to help all of them, as well as the community, to bring the high standards of care to our subspecialties. This is our website, which I would really invite everyone to come and visit. Can you see it on the monitor?
Not yet, Prof.
Share it
Let's
first.
project this slide, please. Okay, so you see this website?
Not yet.
Can you share your screen, Professor?
I'm sharing it now. I'm projecting it in my computer.
Can you share from Zoom program, please, from the green icon?
The Zoom, okay, all right. So if we go here and then here we are.
Yeah.
Yes.
Okay. So this is the website, which I would really invite everyone to visit it. Here's Dr. Musa'ad Zahrani, the president of our international conference last year. And it's a well-active society. And I'm sure you're going to find a lot of interesting points for educations, for training, as well as for public information. One of the things I would really stress on it is that we already started the virtual classrooms. And this is one of them that would bring people together and share their ideas. And almost we are covering all levels for the resident, for the consultant, and even having just a gathering of NET doctors together to bring up their ideas. So the platform of our society is this website. One of the things also I would like to invite you to visit is the multimedia. And under multimedia, you'll find videos and many things under videos. One of them is the speaker corner. And a lot of videos from highly expert in ENT field is talking about their advices and experiences. So this is from the society side, and the good things that we have 8 subspecialty in ENT, and this would bring high variations in handling this kind of pandemic. We have people who are expert in cancers. In those cases, they almost need a special kind of treatment. I would not go in detail in this directions because we have Dr. Mohammed Al-Garni, who's the top expert ENT doctors in Saudi Arabia in this field. And also the airway. And we are lucky to have Dr. Talal Al-Khatib, one of the scholars in this field in Saudi Arabia, who will talk about it in details. But the other subspecialties, they are all involved in these situations and different practice in education and research. And if you allow me, I would like to have a short presentation about what we are trying to do in different aspects. And one of them is to try to build a relations between medical field and non-medical specialists to find a solution for this pandemic. We are lucky in King Saud University to have very advanced centers in artificial intelligence. And we thought this is maybe one of the solutions that we can use to handle this pandemic and to be face-to-face. And by having this kind of networks in the artificial intelligence, we could one day hold this spread of infections. One of the things that really people are questioning with this huge medical power we have these days, with highly professional people in all subspecialties, with all the hospitals, highly qualified hospitals, with the huge data, with high communications, with the registry almost for everything, with a lot of financial support, and also nowadays the full authority given to the medical service and the whole world together. A lot of people think we failed to control this pandemic. Some people, they give it a different name. They could call it paralysis or breakdown. In reality, it's not true. This is something different than what we are facing now. The COVID-19 is a pandemic, and for many years or decades, this has never been happened. And we are talking about rapid and predictable way of transmission of this disease. And also the medical service were not prepared fully for this kind of disasters. Not also to forget that this kind of disease does not have any fingerprint. There's no pathognomonic symptom nor signs. We have still issues with the diagnostic test. So far, as Dr. Musa'ed mentioned, there is no treatment and there is no vaccine. And the best knowledge we have is the number of deaths so far. This is the article which just been published in Science in April 14th. But for the records of COVID, this is considered late. As Dr. Musa'ed said, in daily way, we are updating ourselves how to handle these issues. And this paper was published in April 14th for studies done in 26th of March. And at that time, they said we're still in the initial wave of the disease. And until now, we think we're still in the initial phase of the disease. And the scenarios, according to their models, they think the social distancing could continue till 2022 and the surveillance till 2024. So are not handling an easy disease. And one of the major issues we are facing in this disease is the dilemma in the diagnosis. We have hard time to screen all the people who got affected with this disease. And the limitation we have, because these devices are in the hospitals, and to be going there, there's high chance of contaminations. And for example, there is almost 14% of the medical professionals get infected with this disease. So this is why we are trying our best not to get people to the hospitals and try our best to give them the maximum medical treatment away from reaching to the high infected areas. One of them is the hospitals. The problem with the screening that you cannot screen everyone. We are not able to screen the carriers. Even the disease, we are not screening all the diseased people because there's a lot of limitation in this. And also we cannot screen the all recovered people. So we're still having a sample that are not diagnosed, they're still present and they could transmit the disease everywhere. The best things we are doing for screening is the temperatures, and even with the temperatures, we could miss 12% of the cases who got infected with this disease. The one way of doing it, this screening, is the nasopharynx, and this one sometimes could have low sensitivity up to 63%, depends on the timing of this kind of screening. The best yield of sensitivity in this disease is bronchoalveolar lavage, which is extremely late to reach to this point. And the PCR showing sensitivity in some studies in up to 83%. In some Chinese early publications, it went to 83%. And this is why we heard early in this disease that we were suggesting going with the CT scan rather than PCR to diagnose this pneumonia. This is why some health professionals are advising not to look to the number just by itself, not to count on the numbers, rather counting on the precautions we have every day to avoid any close contact or trying to, and also to keep the hygiene. And what we are trying so far in the medical field is to flatten the incidence curve. And by this, we're lowering the need for the medical services. And we saw what happened in Italy, where they could not control it in this proper way. And this is why we are stressing too much on curfew, education, isolation, and hygiene. And everybody trying to be under the WHO umbrella to collect more and more data and come with international recommendation rather than this isolated treatment here and there. So basically, we're trying to stop the flood from going to the limited resources in medical field, in particular the ICU. I hope I could explain it easy way as H2O, which is water, home, hygiene, observation. These are the cornerstone of handling this pandemic at this stage. What we propose in our field, this is one of the research projects that we are looking for to be funded, that we go toward the virtual hospitals. And by this, we have an easy way of controlling more cases with limited cost. And those virtual hospital, the easy way to look at it is A, B, C, D, to be accessible for medical service and patient, to be covered by board specialized people, professional service, confidentiality, collecting the data, and available of emergencies. And this is not being new. In Australia, in April 8, they already started this virtual hospitals. And there's a lot of devices that could help to monitor patients and keep them away from the hospitals. In Saudi Arabia, I think this has a huge potential for this kind of interventions. We could easily manufacture those devices. And this basically almost like a computers, like Compaq and Dell. But the most important things is to collect our own data and build up a software and be like a Microsoft and Apple. And this has really low capitals, low cost with high margin and high volume. And looking forward to have this huge data to build up a center of excellence that could easily acquire all the hardware. And the data is the new oil for us. And as much collecting data we have, as much as we could control a lot of medical and non-medical problems in Saudi Arabia. The artificial intelligence is the way of getting all these power together. There is no human brain that could be able to collect this huge data and analyze them and come with clear plans. So the idea here to use the artificial intelligence to be a dynamic, flexible, fast, and building future plan for all kind of epidemic. And this would provide service with high quality, high capacity, minimizing the cost and exposure, and minimizing also the hospitals and the professional powers. Not only that, but also will prioritize the medical service and the plan for the medical service in each situations by building virtual hospital, building telemedicine, proactive interventions, and building high standards in treatment of any medical problems. And also this will open wide spectrums of treating any medical problems. And instead of having all of them in the hospitals, we can treat patients in their home with minimal cost and with better service. The artificial intelligence is the way of collecting this huge data for everyone. And the beauty of that this artificial intelligence could easily individualize persons and make a baseline for each one and monitoring them and build up a dynamic tuning for the outcome based on the feedback. And also it's a remote way of doing it. As we said, it's prioritize the medical service and the need, and also will keep this solid for the countries, keeping the way of cybersecurity, the blockchain of protecting all the data. The weakness of this is it's a paradigm shift. Like it's not easy for the medical doctors, not even for the patient to accept going to virtual hospitals. It's need a lot of support. The device is unavailable to cover the whole needs, and who would be able to control the data and the cybersecurity. In fact, the WHO already went in this directions, and they were thinking about the ID 2020, which being proposed by Bill Gates. And that would really support the medical service by telling how the medical service for all nations, how they could collect it, how they could monitor the disease in their countries. And also this will open huge futures for medical service. For example, also the EEG, we can also monitor the EEG of any individual and monitor their medical problems, like for example, the high blood sugars at night while they are sleeping, or the high blood pressures, and then monitor their medical problems and treat it according to the measures of EEG. So it's really a technology that blew my mind, and we think this is the way of medicine going to change in the futures. And I'm sure all of us heard about the artificial organism and possibility of this virus being created by some labs. And this may happen in the futures. And the only way to control this kind of medical disasters is by artificial intelligence. And this is one of the speech of Obama, who talk about this kind of pandemic 5 years ago. Exactly 5 years ago, he said this could happen. I will leave you with this short presentations.
We have to put in place an infrastructure, not just here at home, but globally, that allows us to see it quickly, isolate it quickly, respond to it quickly.
Ironically, 5 years
so that
ago.
If and when a new strain of flu, like the Spanish flu, crops up 5 years from now or a decade from now, we've made the investment. And we're further along to be able to catch it. We have to.
I think if we did it 5 years ago, we could easily save $1 trillion the cost of COVID-19 in 2020, and the cost people estimate to reach up to $4 trillion for this pandemic alone. And the future could have another pandemic that the only way of really controlling it is by having a powerful medical service that anticipate, plan, and direct your medical service in the proper way. I hope I'm not spending a lot of time in my presentations, and thank you to listen to my presentation.
شكرا Prof. It was amazing, beautiful. We were very صراحة amazed by this lecture and these ideas. We really hope that one of your ideas come, inshallah, into the reality. You have done it before, inshallah, you will do it this time.
Jazakallah khair.
So we'll move on to Dr. Mohammed Al-Garni, who is one of the pioneers in head and neck oncology in Saudi Arabia. I'm sure he is still busy in his practice. I know that oncology people are still operating, seeing patients. We envy him, honestly. So please, we are eager to listen to you, Dr. Mohammed, and your input about this COVID-19 effects on your practice.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أفضل الأنبياء والمرسلين. At the beginning, I would like to thank you, Dr. Moussaad. It was really a great chance for me to be with you in this virtual room. Let me say virtual auditorium. The move is great, and I think everybody is enjoying what we are doing. Myself, it's so amazing for me to share all opinion from all over the kingdom and outside the kingdom. Thank you very much again. I would like to share with you my presentation. I'm going to talk today about the effect of COVID-19 on our head and neck system. Just let me know if it's clear or not in the presentation. Can you see it now?
Not yet.
It's coming. Yeah. Yes. Now it's visible.
Okay, perfect. So it's the effect of COVID-19 pandemics on head and neck cancer. I wouldn't add any or more information, I think.
Go
Yes?
for projector view, please.
Yeah, this is projector view.
Yes,
Yeah.
okay.
Okay. So I wouldn't add any more from the information point of view. Most of the information has been mentioned before, Dr. Msaad, Dr. Abdul Hajar. So probably I would like to elaborate more on what we are doing nowadays in the kingdom, at least in our center place in Jeddah, regarding the effect of COVID-19 pandemics on head and neck cancer. So thank you again for the invitation, Dr. Msaad. Thank you for the Society of Saudi Otolaryngology Society. At the beginning, these are my references for the presentation, the ESMO guidelines for the oncology, American College of Surgeons, and also the Association of Head and Neck Cancer Oncology, Canadian Association of Head and Neck Oncology. These are the main references of this presentation for anybody who wants to go back and see what are the recommendations of these institutions. So you can see that we are rapidly increasing. We have a rapid increase in the numbers of cases of COVID-19, and all resources now becoming more and more of scarce resources. So we have to be very, very wise in decision making for patients with head and neck cancer. To start with, dears, there is no, unfortunately, there is no evidence-based guidelines for head and neck cancer treatment during COVID-19. What we are doing here is just giving opinions and sharing the expert opinion from other institutions. So believe me, although it's not evidence-based, but they are very well-respected opinions, very well-respected recommendations from different institutions, because it has been based on a previous informations of survival of head and neck cancer. Some facts about COVID-19, which has been mentioned by my colleague, Dr. Hagar, Dr. Msaad Zahrani. The first fact is that it's very highly contagious. The virus is very contagious. And the other fact is that otolaryngologists and head and neck surgeons are at a higher risk of infection. Not infection only, but also they are at higher risk of severe infections. And that's because of the viral overloads that everybody know that the viral overload in the vicinity of surgery of ENT is very high. We are limited of the gears, full gears of PPEs. And imagine if you have 30% infection rate, 15% of those patients are asymptomatics. That means if you are taking 20 patients to the operating theater, one of those patients will be positive. So one of 20 patients who are asymptomatic will be positive for the coronavirus in your place if you have about 30% infection rate, which is the average infection rate. The other important thing is that, as Dr. Hajar mentioned before, is the sensitivity and specificities of screening of COVID-19. PCR, as you know, it's although highly specific, but it's less sensitive. That means if you have patients with negative COVID-19 based on the screening, that means there is a chance of contracting the infection with a negative screen. So it's very important to consider or to take care of patients who are negative for coronavirus, especially in a highly prevalent area of coronavirus. Another important thing that I like to mention, and everybody knows, is the aerosolizations of the droplets. Now, you know, the infections of coronavirus or the COVID-19 is a droplet infections. Unfortunately, if you take the patients to the operating room, this will change from droplets to aerosolizations or aerosols. And our procedure in general are considered aerosol generating procedure. And that makes the virus from droplet infection virus into airborne infection virus. Dr. Msaad mentioned before that there are 14 patients out of 14 patients in the theater in Wuhan city. They contracted the infection because it has been, powered instrument has been used in a skull-based surgery of ENT and neurosurgical patients. Imagine that the surgeon, nurses, housekeeping, everybody, anesthetist, technician, all of them, they get infected with this procedure. So aerosolization is a major risk in ENT if we consider those patients for surgery. So all our head and neck cases are considered aerosol generating procedures. That means we have to be very well prepared before embarking on treatments or surgical treatment for those patients. The viral loads, two-factor importance in the viral load. I mentioned before that the viral load in the nasopharynx and the larynx and the pharynx is very high. And also the time exposure for patients with head and neck surgery is very high. So this will put the surgeons under the risk of having severe infection and severe infection of the virus. And this is the report from Johan. They reported 14 out of 14. They contracted the infection from ENT procedure. So you have to have a full gear of PPE before starting surgical treatment for those patients. And consider all your patient as positive before you start your procedure. Not to protect yourself only, but also to protect all the personnel in the operating room. During the COVID-19 pandemics, the management of head and neck squamous cell carcinoma has a little bit changed. One of the changes is that we don't have tumor boards anymore. So, but we still do virtual tumor boards. So I encourage everybody in this room, when you are managing patients with head and neck cancer, to still do a multidisciplinary team approach for management of head and neck cancer. And as you can see in this virtual room, we are doing meetings in the in webinars, and you can consider tumor board remotely. So we're still doing head and neck tumor boards on a remote basis. The other important thing is at the pandemic stage. You consider the pandemic stage if you are dealing with head and neck cancer. And the last thing to consider is the mode of treatment. Now, WHO has divided the pandemic stages in regarding the resources or the hospital resources into 3 phases. Phase 1 is the semi-urgent setting, which is the preparation setting, where you have few cases of COVID-19. The hospital resources are not exhausted, and you still have ICU beds and ventilators. This is phase 1. So, and we'll talk about phase 1 and how we are dealing with phase 1 in regard to head and neck cancer. Phase 2, if you have urgent setting where you have many patients of COVID-19, there is little ICU beds, little ventilators, and also you have a limited resources in the operating room. This is phase 2. Phase 3, where everything is redirected to COVID-19 patients, everything is exhausted, you have no more ICU beds, no more ventilators, and the health workers are occupied by COVID-19 patients. And the management will be based on these 3 categories that has been divided by the WHO regarding the resources of your hospital. So tumor board is number 1. Then after tumor board, you consider the pandemic stage in your place. Then you decide what to do for your patients. These are few rules that I would like you to share with me. These are the rules that you can apply during the management of head and neck cancer. Number 1 rule is to respond to the pandemic crisis in a very judicious way and very wise way. Number 2 is to support your colleague and community. Now, if you are treating a patient with head and neck cancer, you have to shift your interest to the community rather than to the interests of one patient. The third rule is that if you can delay the case without affecting the survival, that would be better. So you have to think about the survival of the patients and the effect of the delay on this patient. And this point is very important. I will elaborate when I talk about specific cancers. And try to have non-operative option if survival is not changed. So the options of no surgery is better than the option of surgery in this pandemic stage, and try to shorten the procedure if it's feasible. Now, if you're doing a flap for a patient with head and neck cancer, try to choose the flap that has a shorter time. For example, if you are doing resection of the mandible and the tongue, and you are planning to do reconstruction of the free flap, it's better to have a faster flap like big major flap, make it easy, and make the exposure of the personnel to the virus less. Then modify your chemotherapy as per protocol. Now, as you know, when we treat nasopharyngeal carcinoma, we give new adjuvant chemotherapy for advanced cases of nasopharyngeal carcinoma. Now, new adjuvant chemotherapy is highly toxic and exposes the patient to neutropenic fever, and those patients will be admitted and exposed to the infection rate. So it's better to modify the chemotherapy of new adjuvant chemotherapy and stick to the protocols if the survival is not going to be affected if you change the treatments. And all cases that are going to be operated should be tested for COVID-19. This is an important question you ask yourself as a head and neck surgeon. What's the impact of delay on the treatment of initiation of treatment in head and neck cancer? It has been reported that up to 6 weeks, there is a little effect or impact on the survival of the patients with head and neck cancer. More than 6 weeks will expose the patient to higher chances of death from the cancer. If you expose the patient to 60 days, the risk of this is almost imminent. So you have to consider this fact in mind for choosing what kind of treatment or delaying patients for head and neck cancer. Mind you, this is applicable generally in head and neck, but in nasopharynx, for example, the time is quite shorter and is about 2 to 3 weeks, is going to affect patient survival. So the time of delay and effective initiations of treatments is very important factor to be considered during the decision making. So what to do during the phases of pandemics? Now, if you have a pandemic phase 1 where surgery should be restricted to patients whose survivorship will be affected if you delay more than 3 months. So that means we can do all head and neck squamous cell carcinoma patient in this time of the pandemic and should not be delayed. But we consider modifications of treatments. As I mentioned before, we can consider that the patient has shorter procedure, less aggressive kind of reconstructions, and after testing and full gear of PPEs. You have to make sure that all the personnel having protective measures, avoid any powered instrumentations, and do the test before embarking on treatment. This is phase 1. So all head and neck cancer can be done. In phase 2, where you have so many patients of COVID-19, limited resources of ICU, ventilators, and the system is limited now. So what to do in this situation? The reverse is true now. All patients should be delayed, except those patients with aggressive pathology or whom they have a behavior with invasions to the neighboring structures. Like, for example, if you have thyroid cancer that invade to the airway, that need to be treated immediately. In this case, also, you have to consider alternative. If you have a patient with laryngeal cancer and the pandemic stage is a stage 2, you can consider not to do surgery and go for chemoradiation therapy if that's feasible. So in phase 2, the reverse is true in regard of whether to delay or to do the surgery. I'm sorry, I think I missed phase 3, but in phase 3, let me go back and I just remind you with phase 3 where all the resources is shifted to COVID-19 care. We have very limited ICU beds, we have very limited ventilators, and everything is exhausted. In this case, all cases should be delayed except the 3 indications, which is emergent indications, like airway compromise, number 2, bleeding, if you have tumor with bleeding, or if you have tumor that has an infection, need to be drained. In those cases, you have to do the surgery. Otherwise, everything has to be delayed until the crisis is over. So let's talk about specific cancer. For example, if you have a nasopharyngeal carcinoma, the general rule is that if it's in pandemic phase 1 or phase 2, you have to treat it and avoid neoadjuvant chemotherapy. Replace the cisplatinum with carboplatinum because that will make the chemotherapy less toxic and less chances of admission to the hospital. If there is a pandemic phase 3, delay the surgery or postpone it until the crisis is over, unless there is an airway compromise. It's important to mention the thyroid cancer because thyroid cancer is very common and there are a lot of questions about thyroid cancers. There is a recommendation on not on evidence, but based on an expert opinion, saying that most fine needle aspiration procedure for patient with thyroid cancer, I mean, highly suspicious thyroid cancer can be delayed for 6 months during the COVID-19 pandemics. The data has showed that there is no change in the prognosis if you delay thyroid FNA. Now, if you have well-documented patients or histology-proven patients with well-differentiated thyroid cancer like papillary thyroid carcinoma, if the patient has a low risk and there is no aggressive pathology and it's non-invasive, those patients can be delayed for 3 to 6 months if the pandemic stage, either stage 1, stage 2, or stage 3. So there is a good time for thyroid cancer to be delayed until the crisis is over. In summary, you have to determine the stage of the pandemic in your place. If you are in a pandemic stage 1, all cases of squamous carcinoma of the head and neck should be done. You try to modify your treatments by changing the reconstructions and modifying the chemotherapy if it's nasopharyngeal carcinoma. All patients should be done except patients with low risk well-differentiated thyroid cancer. Now, if you are in the stage of pandemic 2, where you have limited resources, all patients should be delayed except patients with aggressive pathology or aggressive behavior. If the pandemic stage is 3, defer everything and do only patients with airway compromise, or if there is a bleeding, or if there is infection need to be drained. Otherwise, you have to defer the cases until the crisis is over. By this slide, I end my presentation. I would like to thank again the Dr. Saad, organizer for this virtual meeting. Thank you very much. And for all the audience all over the world. Thank you.
شكرا جزيلا. Thank you very much, Dr. Mohammed. Very informative. I have received already some questions, but we will leave it till the end of this lecture. So thank you again. Please, if you have any question for Dr. Garni or Dr. Hajar, send it in the question and answer part. Now, part of our specialty is training. And it's important because we don't know when this will be ending. Our residents are part of the patient care, as well as they have necessity of training. Dr. Mohammed Al-Garni has given his advices to shorten the procedure time. This is if the resident goes to the OR. So I expect that the senior consultant should take over and finish as soon as possible the surgery. Now, what about those who has no chance to go to the OR in elective, in otology and rhinology? It is a big question. The second is we are going now for the end of year exams and the evaluations. How are we going to expect to go smoothly, inshallah, without problem? Also, the rotations now, hospitals are trying to protect its personnel and avoid newcomers, either from resident or from etc. But now the residents are stuck within their hospitals. They cannot, they finish the rotations, they are expected to go to other rotations. Is this going to affect them? Dr. Talal, I'm sure you can enlighten us about these problems for the sake of our residents and for us also, and sure that you have a lot of things to discuss in your presentation. Dr. Talal, the mic is yours.
Thank you very much. The Saudi Council for Health Specialties put in their mind the training of their residents, the well-being of their residents, and also the residents' responsibility for the country as manpower to help in pandemics. It's like a war. We're fighting a virus. So yes, training is part of what we do, but also we have a service to our country and to our nation in helping them. Having said that, we had really meetings and at different levels, at the level of our own otolaryngology board, and also as a member of the Central Training Committee in the Saudi Council. All the programs have the same challenges. And I listed some of the challenges, the main challenges here in the slide, where what are we going to do with our clinical rotations? Like you said, hospitals are they don't want to have cross infections between hospitals. So everyone has to stay put in their assigned hospital at that time. What shall we do with our teaching, where it was organized and scheduled on a weekly basis at the Saudi Commission locations across the kingdom? What shall we do with continuous assessment exams and also the final exams, qualification exams? All these have been discussed at the highest level. So let me take each one of them. I'm not going to spend a lot of time. It's just highlighting some of the points. So the first is the academic teaching, and I have to raise the hat, or lagal, whatever you want to call it, للمتدربين, the trainees, and the local training committees. They've done an extremely marvelous job in taking care and initiative of their educational learning. Usually they have a weekly lecture, and during this pandemic, they have daily lectures. So more than one lecture per day. And the beauty about this is having speakers from across the kingdom. So from 3 to 4, you have one from Riyadh. At 4 to 5, you have one from the Eastern Province, and so forth. The attendees, I was privileged to give one talk to the residents, and I had more than 190 participants. It's more than any number that I've given either in a conference or in a tutorial or in a lecture. So it's good that the knowledge that we have, we are sharing to more people. And I think this is something that we have to take and carry through after this pandemic is over. Similar to this webinar or seminar, whatever you call it, you have more than 800 participants listening to us. I think this is amazing way of education. It's not something new, actually. Universities have incorporated online and distant learning for many years. In fact, when I did my master's in education in Australia, a whole course was online. There were discussions and assignments and chatting happening, classrooms online, just to educate us as future educationists to use this online platform for teaching purposes. And a lot of people say the face-to-face contact is different. It's not like when you're listening. I think if both parties are serious about education, then it's actually the opposite. You see, I'm putting headphones. I can clearly hear Prof. Hajar and Dr. Al-Garni's talks. I enjoyed them very thoroughly. And actually in conferences or in even lectures, you have sidetracked talks, and sometimes the speaker doesn't work that well. The information is not propagated properly. Here, it's like a private teaching session when you have an online talk. It's as if it's one-to-one only, and no one is around. Then if there's questions, then you have, again, collaborative education where, exchange information. So I think the pandemic has taught us that this type of education has been on the side of our attention, while it's a very, very useful information. You can share, like you've seen, you can share slides, you can share videos, you can share pictures. And also the trainees can actually post videos and questions and comments, or even articles that everyone can share. So I think I really want to commend the trainees and the chairs of the local training committees at the Saudi Council. They took this to a higher level. It was a great initiative. What we actually added a little bit as a suggestion for the program directors through the local training committee is to compensate for the lack of surgical training. At the end of the day, we are a surgical specialty. we need the hands-on training. So how can you compensate for what's lost in this tragic time? So I think some of the focus on these lectures should be on surgical steps, surgical techniques, instruments used. For example, the size of the drill I want to use, the type of the drill I want to use. Here I should do a diamond, here I should do a cutting burr, for example. I want to use a size 2.9 shaver blade in this case because the age of the patient is so forth. So I think the program directors and teachers should probably discuss more of surgical steps, either personal videos, what they have in their library, or even the YouTube is filled of surgical steps and procedures with, high-stake surgeons from all over the world, where they actually describe the surgical steps that's going on. So you can just go with your residents on how to do these steps, and this will go into the metacognition of the candidate. It will, yes, he's not doing it himself, but the next time he will come and do this surgical procedure, he would have some background on how to do it. The other problem that we face is clinical rotation. So we're stuck with what we are. No resident rotation should change the hospital because of logistics of the contagious aspect of the coronavirus. Without, like Prof. Hajar mentioned, it has no fingerprint. You might have corona, but you don't know, and you're just transmitting it from one hospital to another. And the worst thing is to have health professional spreading to patients and to the hospital and to the colleagues in health care setting. So we had 2 meetings actually discussing specifically the type of rotations that we can reduce it, or even like in the first year, not necessarily need it in a 5-year rotation to graduate a competent otolaryngologist. Now, mind you that the idea of training is not to graduate a super specialized individual. It's to have a competent general otolaryngologist. So that's really the aim. And I don't want this resident to do a mandibulectomy with a free flap reconstruction or a cochlear implantation, but I want him to know how to do a mastoidectomy, how to do a neck dissection, how to do, if he had his gouted with a neck abscess, a simple FES procedure. So I think that's the aim of training. And if you put that in perspective, we identified that most of our hospitals, luckily, they do these type of procedures. Now, having said that, we understand that because of most of our surgeries are elective surgeries, then it's really affected. So we thought, let's see if the duration. Now, we really, in Saudi Arabia, we got affected by the virus and lockdown in March. So now it's the 3rd month we're in this pandemic, and really no cases that the residents need practicing on. The good thing is, anyways, this is the Ramadan time, and the summertime is coming, and usually most hospitals, some of the hospitals, they slow down during this period. And even patients, they travel abroad, or they don't seek medical attention during this period of time. So to some extent, it's better that this pandemic happened during these times and not early January or before that, where it's the peak of our cases and surgery. Now, what we did is we looked at the curriculum of our training program, and we looked specifically to each rotation throughout each training year. So I'm not sure if the cursor is showing, but for example, in R1 rotations, you have these 12-month rotations from general surgery to ICU to plastics, neurosurgery, thoracic surgery, ER, etc. What we believe, and we benchmarked that we can reduce general surgery, for example, from 12 months up to 4 weeks. But so that's the minimum. So we must complete a 4-week rotation of general surgery in order to be promoted to the next level. And similarly to other rotations, you can see that the majority of our rotations are general otolaryngology rotations, and a 3-month rotation, we can accept an 8-week rotation. So in other words, in the first 6 months of your training, if you're an R2, if you completed, general otolaryngology rotation, and you had some otology, rhinology, and head and neck exposure, in the 3 months, within the 6 months, then we can say that, okay, you have attained the minimum required for this year to be promoted for the year after. Now, this is not, again, something new. Also, the ACGME, the American College of Graduate Medical Education, have identified a minimum requirement for each procedure. So yes, maybe the average national surgeries is, let's say, for neck dissection is 60. But if you've done 27 neck dissections within your training period, which is 5 years of training, then you are competent in doing neck dissection after you graduate. So, and this is a reduction of 1.6 times. So a reduction in the number of the usual, let's say the resident would say, my colleague who graduated has more opportunity than me because of this COVID pandemic 19. In fact, you probably have done more than you need. So these are the minimum requirements. And if you've done the minimum and if you've done more, and sometimes the residents would feel it, that I've done enough, let's say, sinus surgery. It's been a repetition of what I'm doing, especially in the senior years. And probably they would actually go and let the R4 or R3 perform these procedures with them watching and maybe guiding them. And that's what we need from a leadership perspective for the residents. The other thing also we need to highlight is that it's not just surgical, we're not robots, we're not just trained to do surgery. We have many competencies in the training that we need to take care of, namely communication, leadership, becoming an educator. So these things may be missed in the months of training to becoming a professional surgeon. And maybe this break in the COVID-19 lockdown has maybe geared residents toward this leadership and toward more education. And at the end of the day, it's the accumulation of knowledge and skills in 5 years. It's not this 6 months, it's gone, I cannot compensate for it. And this has been happening in educational institutions, not just for pandemics, but sometimes the institution is on probation. Sometimes, you lose a staff and he goes really missed from what he was doing in this institution. And the institution has to fill the gap in that hole. But it may not have a big effect in a training program that is 5 years long. What about the continuous assessment methods during this pandemic? Now, exclusively for this era, we have actually changed some of the continuous assessments that has been approved and announced to the residents during this pandemic, before that pandemic, sorry. So if you can see here, to assess educational training, you have 3 domains: knowledge, skills, and attitude. So what we have for knowledge previously is written exams. We decided that it might be difficult and maybe we're not ready at this stage to do an online exam at site in the Saudi Council or at homes where we can actually assure validity of the exam and all aspects of cheating and network breakdown and people missing their opportunity. So we changed it to a short oral format where the program directors would lead the way in their hospitals. And we left either to make it on the same day and the same content to the local training chairs. They will decide whether it will be simultaneous at once in the whole kingdom, or it will be on different dates. But I think it will be on the same day for all throughout the kingdom. The other part is the skills, and it was mentioned in the book that it's research and it's been for a few years now. Now we said, if you've done research, that's well and good. If you want to do research during this pandemic for COVID-19, also it's recommended. But also if the Saudi Council have initiated an online course to prepare physicians for helping their hospitals and institutions and the country in this COVID-19 pandemic in dealing with ICU patients. We understand, like Dr. Al-Ghani just mentioned, we have phases in this pandemic. And if we reach phase 3, everyone has to help I just had a meeting this afternoon in our local training program committee, and the ER physician said we don't have enough people to help if things went in the worst case scenario. So everyone has to help. Like I said, we are at war with this virus, so and it's part of your training. People who trained during the World War II, they had to work in the war, and they had to do, surgeons had to do fractures and do other stuff, and it built in their personality. It's, I think everything, if you can do something, it will help you somehow. And you don't know when it will help you, but it will help you. So we decided that this online course for ICU, once you finish it and you pass it, then it will be used as a promotion item in your skills. Finally, the attitude, we kept it the same as the in-training evaluation by the hand of the program directors. In terms of final examination, this is the final aspect of challenge. The part 1 examination will be delayed until September. Again, this is a lot of time to prepare for this exam. And I think also for the final examination, which we still don't know when is the date for it, I think it's a great opportunity to compensate for lack of knowledge, or maybe the R5s didn't have time because they're operating, to consolidate their information now. I don't think you have to look at it the bright way. I think it's a great opportunity to go through the books and get knowledge, because after you graduate residency training, I think you stop learning as much as you were a resident. You still learn and go to conferences, but the maximum time you learn during your career is during these 5 years of training. Now, what's after COVID-19 pandemic? I think we should really consider continuing this online learning. It's great. I think listening from surgeons from other provinces, it gives you another perspective of surgery. It gives you another perspective of thinking, in addition to the people you're working with. Second, I think residents are not medical students. They're adult learners. So they have to run after their competency. If I lost a rotation in otology, let's say, then I should, if I'm not an R5, should, after this pandemic finish, to look after these cases and go, even in the private, if I have to, go to the private hospitals and private settings to watch these surgeries being performed. And the other thing, I think that hospitals will open up somehow more OR time or extended hours or whatnot to accommodate for these patients that did not get a chance to be treated. Patients with nasal polyps, patients with allergic fungal sinusitis need to be treated. We cannot wait for that many long time. Even Dr. Garni mentioned thyroid patients. After 6 months, they need to be operated. Now, they've been waiting for longer than that because of stacked OR lists. So I'm sure there should be a solution for that somehow. Now, and the final thing to the residents is not to underestimate the hands-on courses. So the temporal bone dissection course, the FES course, the head neck dissection course, the airway courses. I think these are an opportunity, especially in our specialty where it's a one-man surgery specialty, is to have more of these. If the Saudi Council told you you need to do 2 temporal bones, do 5, do 6. Do as much as you can, even after you finish. If you think that you're still weak in certain areas, sinus surgery, I'm not happy 100%. Do FES course, travel, go to BJ Wormald in Australia, go to Kennedy in the States, go to Europe, go to locally we have esteemed courses all over the kingdom. You can get whatever missed during this pandemic, inshallah, from these courses. With that, I thank you very much for your time. I'm happy to take questions. Thank you very much.
شكرا جزيلا طلال. Very informative. As usual, the Saudi Commission and the Saudi Council are well prepared. Most of these information are, I'm sure, updated on daily basis or weekly basis. So thank you very much. By Dr. Talal, we conclude our lectures. We do have a lot of questions coming. We'll do our best to answer these questions. Some of them are here on the Zoom, some of them are on the YouTube. So we'll do our best. We still have about half an hour, so I encourage my panelists to give short, directed answers. So, and for our participants, please, if you have any questions, hesitate to ask. Iman, she's asking how to overcome the need for visual examination for best diagnosis. I think Dr. Hajar, Prof. Hajar, you have addressed this. Do you have any idea how to avoid the need for visual examination for best diagnosis? I believe what she wants is to diagnose the patient without seeing him.
I'm not sure if I understand the question correct, but I think nowadays it's available in the artificial intelligence and in the communications, that a lot of things we can do to visualize even the throat, the ear. Maybe some of the exam extremely difficult, like the nasopharynx, the oropharynx, the larynx, and these things. But there is a new technology available now, and you could see it in YouTube's, that it has been used to examine patient. And one of them, they do it for COVID-19. They, some country, they send kits to the patients, and with direct communication with the patient, they ask them to open his mouth, put the sensor in his lung to see how he's breathing, how his lung, how his heart rate. So these are available, I think, technologies, and I hope in the futures that would be another things that we could help our patient, in particularly elderly or people who are not having clear or fast access to the hospital, that they can be examined and will support it.
Thank you very much. Rosemary, she's asking Dr. Garni that you do the protocol for every surgery, I expect. Talking about the COVID-19 and the PPE and the preparations. Now, her question is, what about the regular clinic? You see patient definitely of head and neck in your clinic. What are your precautions? Unmute your voice. Yeah.
Yeah, for the thank you for the question, Rose, and I for the examinations. Now, most of our clinics are virtual clinics or phone calls. Now, for example, in our place, in our hospital, what we're doing now is we phone call patients, then speak to the patients, ask them about symptoms. If all patients who have symptoms of cancer, they have to come to the clinic for examination. We can't, deny this. So they come to the hospital, and you have to, during the examination, especially the flexible scope, you have to have the full PPEs. Now, for as I mentioned before, it's 1 in every 20 patients if you have 30% chances of infection rate. So it's quite high. So you have to examine patient with suspicion of cancer with the full PPE, and there is no excuse for that.
There is also the screening at the hospitals. I'm sure that every hospital is applying this. Whenever they come to the hospital, at every gate, there is. So this will also.
Of course. Yeah, everybody is. Measure temperatures at the gate of all hospitals. At least in the kingdom here.
Yes. For you also, Naif Ahmed Fatani is asking about phase 3. He is adding also the tracheostomy for weaning of mechanical ventilations. Would you also consider this if the ICU called you for an inpatient ICU to do tracheostomy? We don't have yet.
We don't have phase 3 till now, alhamdulillah. We're in phase 1. Still, we can do all cases. We have full resources. We have few patients of COVID in each hospital. Maybe few hospitals they are full of COVID-19. But in most of the hospital, we are fine. Now, tracheostomy, even in phase 3, is considered emergency. Because if you're doing tracheostomy, you're trying to evacuate ICU. We need ventilators and ICU beds. So it's considered like emergency. You have to do it, and there's certain guidelines how to do tracheostomies. Of course, full gear of PPEs, plus trying to avoid any contact with the secretions, make the patient fully paralyzed, suppress cough during the procedures. All these are precautions to be done for tracheostomies.
Excellent. Dr. Talal, as a note, unmute please if you have a question, Talal. Unmute.
Well, I just, on the same subject of tracheostomy, I saw two questions in the chat. If you allow me, I'll just, Dr. Ra has mentioned any experience with tracheostomy in the COVID-19 era, in Saudi Arabia, I mean. And Dr. Shamari is asking also, or discussing whether when there's a lot of airway cases post-ICU and intubation, is it better to do a tracheostomy or do a conventional airway surgery? In our hospital, me and Dr. Abdullah Abul Faraj, who's the current fellow, pediatric fellow in the department, have worked on guidelines for the institution. It's actually based on multiple publications and guidelines, recommendations. There's the Canadian, there's the NIH, Europe, UK, and also Australian guidelines, and we had to really convince the administration that, like Dr. Ghani mentioned, these are aerosol generating surgeries. They are high risk. They're not to be taken lightly in terms of full PPEs and testing also. We know that testing is a problem, but we think that, and we believe, and we stuck to our idea that every patient going for airway surgery has to have a COVID testing. And if that's confirmed, we try as much as possible, according to the recommendations, to avoid doing a tracheostomy. Now, unless the current ventilation settings are not helping, and maybe he's going to go for ECMO and it's not helping, then we think of doing a tracheostomy, and it has to be a multidisciplinary decision. But if he's suspected case, then we need to do it. And most people in the literature talk about delaying the tracheostomy for more than 3 weeks. So making sure that, you know, the period of viral transmission is subsided. Unlike, you know, the 2 week that we are used to say that we have to do it in 2 weeks to avoid complications of intubation. And obviously, if he's negative and he's not a suspected candidate, then we should do it with the precautions that he might be a carrier to the virus. Now, I think Dr. Shamari's comment needs a whole discussion. I don't think I'm going to dwell into that. Maybe for another meeting on how we deal with post-intubation cases.
Thank you. There is this question from Dr. Zahra Al-Momin. She's asking about Part 2 exam, Talal. Part 2 exam, are you going to carry it on this year or any?
Like I said, the problem is not only in otolaryngology, it's on all programs in the kingdom. So still there's no decision regarding Part 2 examination, but my suggestion and recommendation to R5s, study for the exam. Be prepared. This is your time. The exam is not for the exam, it's for you to be a competent physician after you finish training. So this is an opportunity to build your information and knowledge as an otolaryngologist. Don't think of the exam. The exam is just to make sure that you actually are competent enough to pass and practice. But your focus should be on being the best otolaryngologist possible. And it's a great opportunity now to theoretically be very good.
Great. Now there is Rahman Sharif, he is asking, well, philosophical question, I would say. Which is more dangerous, a patient to patient of COVID-19 or cancer, especially the aggressive type? I believe he's asking which is more dangerous, the COVID-19 or the cancer in phase 2 or 3. So should we consider the comorbidity and the age of the patients, which put the high risk of COVID-19 in selection, and whether to operate or delay? Meaning, I believe Dr. Garni is asking whether we consider the age and the comorbidity of the patient in our criteria of selection to operate or not.
Well, regarding the most important is determining the pandemic stage. This is the most important. Now, if you are in a stage that there is no resources, all resources should be directed to the COVID-19, which is very unusual situation. Maybe it has been faced in Italy or Iran or some maybe in New York City, where everything has been directed to the COVID-19. In this situation, all patients with cancer has to be delayed. They have to be delayed because most of them, they can wait for 2-3 weeks until the crisis is over. Now, if you are in a pandemic stage 1 or stage 2, you have to be highly selective. It's a clinical decision. You have to put the community first, then the personal or the patient's interest second. But for a situation where you are, if you are similar to New York City or to Italy, there is no chance to do any cancer unless there is an airway compromise or there is a patient who has bleeding that need to be controlled immediately. That means a life-saving procedures. Otherwise, everything has to be directed to the COVID-19 because it's national pandemic issues. So I think it's not very complicated, although it looks a philosophical question, but it's not complicated. It's very clear. It has been made very clear that the situation of the country, if there is stage 3 pandemics, no cancer patient has to be done. And this is based on at least what we are doing in our institution based on the American College of Surgeons recommendations that you have to stop all cancer patients unless there is airway compromise, infection, or bleeding.
شكرا محمد. Khalid Delejan, he is asking the society, Prof. Hajar, he is asking the society if they can give or release guidelines for different operative cases, for example, tracheostomy guidelines in COVID-19, etc. So the ENT would take them in consideration or at least have a guideline to follow. How do you look into this مع the recommendation of the Ministry of Health and the guidelines of the Ministry of Health that are released regularly?
Thanks a lot to Dr. Musa'ad, and thanks for Dr. who make this interesting point here that I would like to highlight that the Ministry of Health actually is beyond our expectation in their plans. And I really would like to lift my hat to the Ministry of Health for their planning and for their regulations in the medical field that really for the sake for the whole communities. And the society, and I think all the society in Saudi Arabia will be, all of them are under the umbrella and extremely happy of all the regulation going on in Saudi Arabia. And this could easily explain how we in Saudi Arabia, we have low mortality and morbidity of this pandemic compared to the other countries. I think there is no problems of coming with standards in Saudi Arabia. And luckily in our society, we have subspecialties in all fields, and we are open in the board to accept any recommendation from any one of them that could come with this better solutions of disasters. I'm happy to transfer this question to the subspecialties in Saudi Arabia, and if they think there's different standards they can come up with airway in Saudi Arabia, we'll be more than happy to adopt it in the society.
Thank you very much for this response. For you, Prof. Hajar, there is a comment from Mohammed Zarani. You might also access it. He's one of the Saudi Commission for Health Specialties, and he is congratulating you for the artificial intelligence lecture and pointing in your presentation. And I believe he is offering you something. Probably he will reach you out. So, put us with you if you have any approval or any certificates. This is amazing to get out of this talk with these results.
I'm open for any discussion in this field, and I think this is going to be the futures. The earlier, the better that we go in this directions, and definitely we're going to save a lot of lives. We're going to save a lot of monies, and this will open huge futures in the medical field. And I think the history of medicine going to change after this COVID pandemic. We're going to call it AC and BC. AC before COVID and BC before COVID and AC after COVID. So the history going to change. We're going to see a different practice. The earlier we go in these directions, the more time you're going to save, the more money we're going to save. And instead of adopting this technology from outside the Saudi Arabia, we could create our own needs and our own practice in these directions.
شكرا بروف. محمد الشهابي من البحرين العزيزة. He's asking if there is any plans on the nationwide for the healthcare workers antibody testing to resume work. If there anything or anybody has any comment on this, or we leave it to the Ministry of Health spokesman later on.
He means post-infection, healthcare workers.
To resume work, is there any plans to test the healthcare workers before resuming elective procedures?
I'm not sure, Prof. Hajar, any idea about this?
I think they do it routinely for anyone who got infected. And I know even for people who are at high risk, before they go to practice again, they end up tested for COVID-19. I remember in the early stage, I came from outside the kingdom, and I got to go for this testing before I go back to practice in my hospital. So I think this is done routinely in Saudi Arabia. I'm not sure how it's been done in Bahrain or other GCC, but I think they are doing the same thing, in particular for anyone in the medical field, instead of transmitting this infection to himself or to the others.
I also have to say that we have condemned the Ministry of Health for great effort, like Prof. Hajar said, in taking leadership in this aspect. And one of the things is taking COVID from most hospitals and putting them in few hospitals and in field hospitals. This way to eliminate as much cross-contamination as possible. And some of the hospitals, like our own King Abdulaziz University, is actually making a new building, temporary building, just for suspected COVID-19 patients, so they don't contaminate patients coming to the emergency department for other reasons. I think this is very, very important. I think the question that's asked is carrying this infection from a healthcare worker into the hospital. And I think what the Ministry of Health is doing, if you are positive, then you have to have 2 negative tests before you are declared COVID-19 negative. Now, lately they've updated their guidelines, because you can be positive for many weeks because of immunity that you have developed. So they've just, I think 2 days ago, mentioned that if you're 10 days after the negative, after no symptoms, then you're also deemed negative.
Dr. Muhammad, and I'm not surprised, most of the questions are addressed to you. Your opinion matters. Dr. Rashid Al-Abri min Oman, a friend and a colleague, is asking for nasal endoscopy during COVID-19. You have mentioned it a while ago. Would you kindly quickly give a comment on that?
Regarding the nasal endoscopy, you mean flexible scope?
Flexible nasal scope.
Yeah. Well, we try to limit this as much as you can. Now, doing the endoscopy, especially in head and neck cancer, try to avoid it as much as you can unless there is suspicion of cancers. In this situation, you have to have our full PPEs, do the flexible scope, and do the sterilization in the regular fashion. And we consider patients who comes to the clinic, which are few patients come to the clinic. Most of them, they are contacted through virtual clinics or phone calls. So when they come to the clinic, we consider them positive. So we deal with them in full protective measures. So if you're doing a scope, we prepare everything like he's positive COVID-19.
شكرا جزيلا. Thank you very much.
I think a point also to learn from this pandemic in the future is to remind us of infection control measures. I think as an otolaryngologist, we underestimate this aspect. And I remember Prof. Dagestani, when I was a resident, Mu'eed Jama, he puts gloves and mask when he examined every single patient. It was amazing for me to see that. But in retrospect, I think it's important if you're examining the nasal cavity and oral cavity, especially if the patient is sick, is to consider that this droplet transmission can make you sick, and maybe you can transmit this to your colleagues and your family at home. So wearing gloves and putting protective mask when you're doing an invasive procedure like nasoendoscopy or laryngoscopy is something we should really consider.
True. Thank you a lot. Dr. Prof. Dagestani is a legend of otolaryngology in Saudi Arabia, and he's still teaching us even after his retirement. يعني نمسي عليه بالخير ونقول له كل عام وانت طيب. Prof. Hajar, let me ask you. It is not an oncology cases, but it is challenge for our children with profound sensory neural hearing loss. I don't know yet. I'm not sure if any of us is aware when this pandemic will be over and when the elective cases will be resumed. But until that time, the Saudi society has any advices on children with congenital sensory neural hearing loss, when to operate on them and implant them?
Very important point, Dr. Saad. We face it in our centers. Our center consider one of the biggest pediatric cochlear implant program on the face of the planet. So we are trying to always come with a type of standard of care that can be used for other centers because of the huge number we are handling, and even small things can easily be magnified and end up positive or negatives. So cochlear implant in particular required almost like the tumor board team. It's a teamwork that everybody has a major roles to play in this treatment. So basically surgeons, audiologists, and speech therapists. For the surgeons, as Dr. Mohammed mentions, we run most of the surgeon clinics by phone call and monitor our patient in virtual clinics. The audiologist and the speech pathologist in our center are doing a great job. And this COVID-19 going to change our practice in the future. Clearly, we are going toward a distance mapping, providing hopefully the patient with the kits, and with communication with his laptops, we could do distant mapping more frequent and more appropriate. And that would save a lot of time, a lot of money. Imagining the child would come with his parents a day before and then spending one day in Riyadh and they leaving the day after, 3 days of work. Their family got compromised, and the cost of the transportation, accommodation, all these are going to change hopefully in our centers by the artificial virtual clinic. The same thing for rehabilitations. Luckily, we have outstanding IT people in our hospitals, where nowadays they start this virtual rehabilitation clinic, and we are extremely excited the way it's been running. And I think we're gonna spend a lot of time developing this way of doing it. For the surgeon, as you know, this cochlear implant is more of an elective surgeries. And it's hard for any surgeons in otology to compete with Dr. Mohammed Al-Garni to take an OR time from him, or from Dr. Talal Al-Khatib for the airway. So those are top priority, safe, life-saving procedures. But the cochlear implants, it's more of an elective surgeries, and we would like to do it for the best time because it's going to be for the patient for the rest of their life. So we want to optimize the whole things for them. We do want to rush during surgeries, and we would like to do bilateral simultaneous cochlear implant in children. So we do want to go back toward the sequential cochlear implants. So all these things really going to matter, and this is why we are delaying the cochlear implants in surgical side. But keeping in mind that those who got implanted, they also would require a lot of services. They would need some maintenance for their devices. They may need batteries, they may need cables, they may need any fast solutions for their devices in case end up with troubleshooting. All these measures need to be addressed clearly in any centers who's doing cochlear implants, and we are happy to help them with the way we are doing it. The other thing also I would like people to pay attention for it is the hard of hearing people who are wearing the hearing aid. Also, those are not uncommon. They need a lot of help, they need a lot of support. And for example, nowadays we have this transparent mask, so people could say their facial expressions and they can communicate with them. The other thing, remember, by wearing the mask, we're losing 10% of our sounds. So we need to raise our sounds and to speak slowly and not to come very close to the others, so we end up with more infection, but at least we have, good distance with the people who are having hearing loss. So by this, we don't compromise the risk of infections, but at the same time, we are having easy access to the people who have hard hearing. The other options nowadays is the communication with the mobile. We can have the facial expressions and we can speak with the people without covering our face. So all this technology can be utilized for those patients. Remember, one thing that I would like to stress on it, sorry, that those people with hearing loss, they end up with a lot of stress these times. And we know stress will reduce their immunity. And this would bring them more at high risk of COVID-19 infections or complications. So we need to put our hand with their hands and support them and help them by all means.
شكرا Prof. I'm sorry for all the audience left out of questions. Comment on you, Prof, without the need for answering. Is there any rule for those who are at the edge of the age for implantation? Can the society come with guidelines, trial of special surgical microscope to cover to reduce the transmission intraoperatively? I think this will leave it for the Ministry of Health, hoping inshallah that they will open up and allow for elective surgeries to be soon inshallah. And then we will come up with inshallah Prof Hajar again another time and give Abdullah Ear Institute and also from the society. I would like to conclude with two questions to Dr. Garni again. One from me and one from Dublin. Dr. Tanveer from Dublin, Victoria, and Ear Hospital. He's asking about how was your experience of virtual clinic in the National Guard Hospital? Is there any comment on that? And my question is, we receive in our oncology center, King Fahd Specialist Hospital in Dammam, one of the major centers of oncology, we receive referrals from other areas in Saudi Arabia. With the lockdown, with difficulty of transportation from an area to an area, what is the best practice to do for those patients, in your opinion?
Yeah, for the clinics at National Guard, regards to Tanvir first. Dr. Tanvir, thank you very much for the question. And for the clinics now, in the National Guard, the clinics are done through the phone calls, virtual clinic in other place. But in the National Guard, we do it through the phone calls. The experience till now is terrific experience. Now, all patients who need, at least we start with those patients with follow-up of cancer patients. So these are the most important for my specialty, at least, or patients with airway post-surgery. So it's very important that we communicate with the patients, we fill medications, ask patients who need to be seen immediately. So we have a very good experience. We have no problem till this time, but it's difficult to judge. We have a short time of these clinics, only 1 month or so. So I cannot judge 100%, but I think for the time being, until we have a real virtual clinics, phone calls would avoid the risking the patients to have these infections or to contract infections, while we can contact them on a weekly basis. So our experience till now is a great experience. Maybe to tell the 100% what are the drawbacks, we need some few months to tell exactly.
The other question?
Again, I didn't hear the other question, sorry.
I have a question for you about the new diagnosed oncology cases, and let's say Al-Bah, okay? And he needs an oncology center. In these days of the lockdown between the areas of Saudi Arabia,
cities, yes. Yeah.
How to advise and how to approach this?
Well, for at least I can tell about our place. Now we have electronic applications for cancer patients. They apply through eligibility of the hospital through electronic applications. Then when they get accepted, they have appointments, and they can come up with these appointments during the lockdown. So they have no problems at all. Referred patients from any city, they have appointments, and by this appointment they can go through the lockdown.
Yes, I wanted to hear this because that's true. That you can get your permission. There are other precautions to do. For example, we request in our hospital that you do a screening test of COVID-19 in your center before sending to our hospital. And then when he arrives to the hospital, we are sure that he is at least negative from COVID-19. But generally, there is no problem of the cases out for specialized oncology center throughout Saudi Arabia. With this, we conclude. It is amazing. 2 hours passed without noticing. It was very enriching. Our panelists, amazing as usual. For our attendees, thank you very much for attending. It was even more than we expected to attend. We had a lot of questions about the CME hours and the certificates. These are with the organizer. There are CME hours, inshallah, you will receive it. I'm not sure how many CME hours. This is in the hand of the Saudi Commission for Health Charity. And it's with the organizer, and you can reach him at any time. Inshallah, we will see you soon in better situations. If our panelist has any final comments before we leave, otherwise we thank you very much.
Thank you very much, Dr. Saad. It was a great opportunity. Thanks.